Okay, I think everything is good. So welcome everyone to the sixth session of Module 2 of the Comprehensive Neuroanatomy Educational Course that organized by the Yemeni Neurosurgical Society in collaboration with the WFNS, World Federation of Neurosurgery, Young Neurosurgery Forum, and Neurosurgery Coach, and also Pakistan Society of Neurosurgeons and Neurosurgical TV. Today we have one topic. We will have Professor Sayed, Professor Sayed Amir Basha, Clinical Director and Professor of Department of Neurosurgery and Neuromodulation at Renova Institute of Neurological Science at Hyderabad, India. So we'll talk today about the blood anatomy of the thalamus. Professor, you can start, please.
Yeah. Hi, everyone. Good evening. I think we are living in different timelines. Should be good afternoon and good evening and good morning to all of you. At the outset, I would like to thank Professor Ahmed for giving me this opportunity. And I also would like to thank Yemeni Neurosurgical Society for giving me this opportunity to take part in the comprehensive neuroanatomy teaching schedules. Today, I will be talking about thalamus, its nuclei, its connections, and then the applied aspects of all this anatomy to help, as Professor Ahmed said, the medical students and the neurosurgical postgraduates and even the young neurosurgeons, and even to brush up the knowledge of the senior neurosurgeons also. To start with, thalamus is a Greek word meaning a chamber or the inner core inside the brain. Even today in Greece, the rooms are addressed as thalami. So this is a chamber within the deeper part of the brain, and it is a collection of the gray matter in an egg-shaped structure, which is placed on the just above the midbrain on either side of the third ventricle with this type of orientation, which is almost like oriented in a 30 degrees angulation with the midline. So this is the anterior part of the thalamus and this is the posterior part of the thalamus. This is the angulation here. This is the third ventricle. And the thalamus develops from diencephalon. As I was telling you, the prosencephalon gives rise to telencephalon and the diencephalon, and thalamus forms a major part of diencephalon along with the hypothalamus and then the epithalamus and subthalamus also. The epithalamus involves the pineal gland, the posterior commissure, habenular commissure, and then the subthalamus has zona incerta, subthalamic nucleus, and fields of force. So these structures, they develop from the diencephalon. And the telencephalon gives rise to all these cortical structures, the frontal lobe, parietal, occipital, and the temporal lobes. And to just give you a brief outlook of orientation of the structures in the brain, I will be dedicating my first few slides to the macroscopic anatomy, like the orientation of all these structures. Because these are the deeper structures, not much of interest is shown into the depth of the orientation of these macroscopic structures here. If you look at this picture, the thing in the yellow color is the caudate nucleus. This is the head of the caudate nucleus, and the tail is capped in the temporal lobe with the amygdala here. And the structure which is purple in color, this is the putamen, and the dark purple color is the globus pallidus, and the green colored structure is the thalamus. Here you can see that the green color structure is the thalamus here. The fornix is going around the or swiping across the thalamus, going into the medial part of the temporal lobe. And this is the caudate nucleus here, and this is the caudate nucleus here, and this is the third ventricle, this is the pineal gland, and then the posterior commissure here. And this is the tectal plate with the superior calculus and inferior calculus here. And this is the temporal horn here as you go down. And then if you look in the axial sections at different levels, this is at the level of the lateral ventricle. This is much deeper to the lateral ventricle. This is the caudate nucleus. This is the internal capsule here. And this is the putamen. This is globus pallidus externa and interna here. And then this green structure is the thalamus. And this is the internal medullary lamina here. This is the coronal section, which is showing the green colored thalamus here on either side of the third ventricle. And these are the lateral ventricles here. Almost this is the choroid plexus here. This picture will be very important, particularly for the neurosurgeons who are involved in functional neurosurgery. This is again a coronal section. This all is the thalamus here. This is the mammillary body, and this one is the third nerve. And this is the optic tract here. And this is GPI, this is GPE, and then this is the putamen. So this orientation is very important when we are using GPI as a target in the deep brain stimulation procedures. And this is again a sagittal section of the brain. This is the corpus callosum, the genu and the splenium. This is the lateral ventricle. These are the fornices. And this is the thalamus here. And this structure is the interconnection between the two thalami. And this is the mas intermedia. And this is the hypothalamic sulcus, which extends from foramen mandibular to the aqueduct. And below that level is the hypothalamus here. And you can see the epithalamus structures here, like the pineal gland, and then the posterior commissure, habenula, and habenular commissure. This is superior colliculus, this is inferior colliculus. You can also have a look about the orientation of the veins here. This is the internal cerebral vein. And then the basal vein will be joining here, and this is the vein of Galen here. And this is cisterna ambiens. I will be showing a different view of cisterna ambiens, and I will talk about something important in the cisterna ambiens. And here, if you see, it is like overlooking from the top to the bottom. This is the third ventricle here. This is the thalamus, which is coated with ependymoma on the walls of the third ventricle. And there is a groove between the caudate nucleus and the thalamus. And deep to this groove will be stria terminalis. Stria terminalis is a structure which connects the hypothalamus with the amygdala. And deeper to that will be the vein of stria terminalis, which is also an important structure in the venous drainage that plays very important role. And this is the third ventricle here, the pineal body, and the superior colliculus here. You can see the orientation of this thalamus on either side. It will be oriented with a 30 degrees angulation with the midline here. The anterior poles of the two thalami are nearer here, and the posterior poles are falling apart here. And if you look at this picture, this is the stria medullaris here. This connects hypothalamus to the habenula. And this is massa intermedia, this is hypothalamus, and these are the epithalamic structures here. This is again a sagittal section showing the septal veins here and formation of the internal cerebral vein here. And this is the hypothalamus here. And this is the roof of the third ventricle. When the septum pellucidum is reflected back here, these are the two internal cerebral veins. When you pull apart the two internal cerebral veins, and this cobweb-like structure is the velum interpositum. And the vessels here, which we are seeing, are the posterior choroidals, the medial branches. And this is the choroid plexus, and the thalamostriate vein will be helping us in the endoscopic procedures in reaching out the foramen of Monro here. And one important thing about endoscopic procedures, once you enter the third ventricle, in women, the massa intermedia will be usually little bigger than the males. And also in patients with neural tube defects, the massa intermedia will be much bigger, and sometimes it hampers our view into the ventricles. And sometimes you may have to resect some part of the massa intermedia to have a better look inside the third ventricle. So as I told you, once you open up the velum interpositum, this is the third ventricle here, and this is the pineal body, and this is the posterior commissure here. All these structures are very important landmarks during the endoscopic procedures to identify the level where we are working and the structures what we are looking at during the endoscopic procedures. And the posterior commissure, anterior commissure, and then the mid-commissural point, they have very relevant standing in the deep brain stimulation surgery planning protocols. And as I was telling you, this is the brainstem here, this is the aqueduct, and this is the colliculi here, superior and the inferior colliculi. This is the cisterna ambiens here. And when you look at the structures, the most important structures in the cisterna ambiens are the fourth nerve, and then the basal vena of Rosenthal, and then the lateral posterior choroidal arteries, and this is the pulvinar of the thalamus, which will be projecting into the cisterna ambiens here. And when we talk about the connections of thalamus, this is the major relay station in the brain. It gathers all information from the head and neck, and then the trunk, and then it processes information, and then it sends it to the cerebral cortex. And most of these thalamocortical fibers will be ending up in the fourth layer of the cerebral cortex. And one beauty about the thalamic nuclei and its connections is when thalamus sends information to a structure, and it gets back information to the same nucleus. It doesn't like overlap, or it doesn't cross to the other nuclei. Even though nuclei has some amount of interconnections, but when it sends information to a structure and it gathers information from the same structure to the same nuclei in the thalamus. That's the beauty of this thing. See here, this is the basal ganglionic structure from the spinal cord, and then the midbrain and the aqueduct and the periaqueduct nuclei here. These are all like have thousands and thousands of connections with the thalamus. And when some fibers project onto the thalamus, most of them they use glutamate as a neurotransmitter, and the thalamocortical fibers will be using GABA as a neurotransmitter. And I have collected all these pictures from KenHub, the website, because I like the color and the orientation of the anatomical structures here. When you look at the gross anatomy, the thalamus, as I told you, the anterior parts are coming closer and the posterior poles are falling apart. And this is the left-sided thalamus. This is the right thalamus, and this is the left thalamus. I mean, this is the right thalamus, and this is the left thalamus. And the thalamus will be covered on the lateral part with a sheet of white matter fibers called the external medullary lamina. And then the nuclei within the thalamus are divided into like anterior, medial, and lateral and lateral nuclei, the groups of nuclei, with a thick vertical sheet of white matter fibers called the internal medullary lamina. And internal medullary lamina itself has some nuclei within that. And then there will be some nuclei on the medial side below the ependymal layer of the third ventricle. In the gray matter, there will be collections of neurons. And on the outer side, on the lateral surface, outside the external medullary lamina, the thalamus is wrapped with reticular nucleus, which is extending from almost the anterior pole to the pulvinar area and even the geniculate nucleus here. When you look at the functional division, the nuclei are divided into three types, like relay nuclei, where it gathers information except the olfactory sensation. All other sensations will be carried to the thalamus. It gathers information and then it processes information. And the most of the nuclei which are involved in this group are the ventral anterior, ventral lateral, ventral posterior, and the medial geniculate and the lateral geniculate nuclei. And the association nuclei are mainly the anterior nucleus, the pulvinar, and the dorsomedial nucleus. They receive information from the cerebral cortex, and they send information to the associated areas like prefrontal and the associate areas in the temporal lobe and visual areas. There are some non-specific nuclei, particularly the nuclei within the internal medullary lamina, and then the paraventricular nuclei, and then even the reticular nuclei. They are like non-specific. Not much is known about these nuclei, even though there are some assumptions, which I will be talking about in my later slides. And let us go by each and every group. This is the anterior group of nuclei, which are divided into anteroventral, anterodorsal, and anteromedial. This is mainly connected with the limbic system, and it influences the emotional states such as attention and alertness and memory acquisition. And the afferents to anterior group of nuclei come from the mammillary nuclei. The medial mammillary nuclei will be projecting mainly to the anteroventral and the anteromedial nuclei, and the lateral mammillary nucleus will be projecting bilaterally and onto the anterodorsal nucleus mainly. And the efferents from the anterior group of nuclei will be traveling to cingulate gyrus, anterior limbic area, parahippocampal gyrus, the dorsolateral, prefrontal, and posterior areas of the neocortex. And when we talk about the lateral nuclei are divided into a dorsal group and the ventral group. This is the ventral group here. This is ventral anterior, ventral lateral, and ventral posterior. Ventral posterior has two parts, like ventral posterior lateral and ventral posterior medial here. And this is the lateral dorsal and the lateral posterior nuclei. And the dorsal tier nuclei also involves the pulvinar and then the lateral geniculate nucleus and the medial geniculate nucleus also. So there is a school of thought where the geniculate nuclei are grouped as away out of the thalamus, but the most of the hypotheses, they include this geniculate nuclei in the thalamic nuclei itself. And this is the ventral anterior nuclei here, just behind the one limb of the internal medullary lamina, and just anterior to the ventral lateral nucleus. And this is bordered by the structures what I described just now, the internal medullary lamina, one limb, and the ventral lateral nucleus. It has a principal part and a magnocellular part. And the ventral anterior nucleus gets afferents from globus pallidus and substantia nigra. Globus pallidus will be sending afferents to the principal part of the ventral anterior nucleus, and the substantia nigra will be projecting to the the magnocellular part of the ventral anterior nucleus. And the efferents will be going to the Brodmann area 6, 8, and then it also gets a reciprocal connections from that area. And it also sends efferents to frontal lobe and the anterior parietal lobe also. It plays a very important role in planning and initiating movements, and it is involved in a phenomena called the recruiting response. This is like transmitting the cortical recruiting response. This is the most important nucleus which is involved. And then the ventrolateral nucleus, it has two parts, like pars oralis, which is located anteriorly, and pars caudalis, which is located posteriorly. This is the ventrolateral nucleus here. And it receives afferents from the ipsilateral internal globus pallidus, mainly to the pars oralis. And it passes, these afferents passes through the thalamic fasciculus. This I will be showing in a separate slide, how this thalamic fasciculus and the ansa lenticularis, all these things are oriented. And pars caudalis will be receiving afferents from the contralateral deep cerebellar nuclei. And additional projections to both these nuclei will be from the spinothalamic tract and the vestibular nuclei and the precentral motor cortex also. And efferents will be given off from pars oralis to supplementary motor cortex and the lateral premotor cortex. From pars caudalis, the efferents will be going to area 4 of the primary motor cortex. The ventrolateral nucleus is active during both active and the passive movements of the contralateral part of the body. It also has a function of relaying motor feedback from the cerebellum to the cerebral cortex also. And this is the ventral posterior nucleus here. As I told you, it has two parts. This is the ventral posterior lateral, and this is the ventral posterior lateral medial part. The structure which are shown in the green here. This is the ventral posterior nucleus. And the ventroposterior lateral nucleus will be receiving information through the medial lemniscus and the spinothalamic tract. And the ventroposterior medial nucleus will be receiving information through the trigeminothalamic pathway, mainly from the head and neck. And the reception in this nuclei is arranged in a fashion of the lamella, and each lamella has a specific representation of a body structure. And even the depth of perception of a sensation, like a deep sensation and superficial sensations, it has a different kind of representation in each lamella. Like ventral part of the nuclei, they receive superficial stimuli, and the anterodorsal part, they receive the deep stimuli. And the neurons located in between these two parts, they receive the most superficial inputs like cutaneous touch and that. So this is the nucleus which is very, very important in gathering a lot of information from both head and neck, as well as the trunk, and it processes information, and then it sends information to refines this information and sends it to the cerebral cortex. And it sends efferents, as I told you, to the Brodmann areas 1 and 3B of the primary somatosensory cortex, and also to secondary somatosensory cortex and to insular cortex also. Usually these fibers will be passing through the posterior limb of the internal capsule and the coronary. And the medial geniculate body, this is the green structure what we are seeing here on the medial part of the posterior pole of the thalamus below the pulvinar. This is an ovoid projection here, and it receives afferents from the central nucleus of the ipsilateral and contralateral inferior colliculi, pericentral nucleus of the inferior colliculus, and the brainstem nuclei of the auditory pathways. And reticular nucleus of the thalamus also sends afferents to medial geniculate nucleus. And the inferior superior colliculi also, they intercommunicate with each other. And efferents from the medial geniculate nucleus will be going to the primary auditory cortex and auditory areas around the primary auditory cortex. Insular and opercular cortical fields also receive the efferents from the medial geniculate nucleus. And this structure in green is the lateral geniculate nucleus here, and the lateral part of the posterior pole of the thalamus just below the pulvinar. And this receives afferents from the contralateral. It has a laminar representation. It is supposed to have around 6 to 8 lamina. And 1, 4, and 6 lamina will be receiving fibers from the contralateral nasal hemiretina. And 2, 3, and 5 lamina will be receiving information from the ipsilateral temporal hemiretina. And the efferent is projected to the visual cortex area 17 and extrastriate visual areas in the occipital lobes also. And this is the lateral dorsal nucleus here. And this is the most anterior part of the dorsal group of nuclei in the lateral nuclear group. And it receives afferents from the pretectum and the superior colliculi. And it has reciprocal connections with the cingulate gyrus, parahippocampal gyrus, parietal cortex, and the precipiculum of the hippocampal formation. And the lateral posterior nucleus. This is the lateral posterior nucleus here. It lies dorsally and just behind the lateral dorsal nucleus. It receives afferents from the superior colliculus, and it has reciprocal connections with the superior parietal lobe, additional connections with the inferior parietal lobe, cingulate gyrus, and the medial parahippocampal cortex. And the big green structure, what we are seeing here is the pulvinar, that is almost like forming the posterior pole of the thalamus. The exact function of this structure is unknown, but it is supposed to take part in the perception, cognition, and memory orientation, particularly in relation with the visual sensation. And receives afferents from the superior colliculus and retina. Efferents will be given to the temporal lobe, cingulate gyrus, inferior parietal cortex, particularly from the medial pulvinar nucleus. And the lateral pulvinar nucleus is connected to the prefrontal cortex, parietal cortex, and the temporal association cortex, and the posterior temporal lobe and the occipital cortex. The inferior pulvinar nucleus projects onto the visual area of the posterior temporal lobe, and the striate and the extrastriate cortex in the occipital lobe. So this is supposed to play a visual oriented perception, cognition, and memory. And then the medial thalamic nuclei. As I told you, this is the green structure what we are seeing here. This medial thalamic nucleus is also known as the dorsomedial nucleus. It is just medial to the internal medullary lamina, and it is lateral to the paraventricular nuclear group of the thalamus. And it has an anteromedial magnocellular part and posterolateral parvocellular part. The magnocellular division receives inputs from the olfactory afferent fibers. The thalamus is supposed to get all the information like sensations except olfaction. But there are certain areas in the thalamus which still get some input from the olfactory pathways also. And it establishes a reciprocal connections with the anterior and medial prefrontal cortex, mainly to the olfactory area on the orbital surface of the frontal lobe, and the ventromedial cingulate cortex, and the inferior parietal cortex, and the anterior insula. And the posterolateral parvocellular part, it establishes reciprocal connections with the dorsolateral and dorsomedial prefrontal cortex, anterior cingulate gyrus, and the supplementary motor. And it also projects efferent fibers to the posterior parietal cortex. So most of the times the discussion will be like thalamus receives every sensation except olfactory sensation. But this medial thalamic nucleus, the dorsomedial nucleus, receives some information from the olfactory area, and it also projects to this associated areas of the olfaction sensation. And the intralaminar nuclei, most of the time the function of this intralaminar nuclei is unknown, and there are various groups of intralaminar nuclei. They are divided into anterior or the rostral and the posterior or the caudal group, and they have a role in the activation of the cortex from the brainstem reticular formation. It is also involved in sensory motor integration, and the posterior intralaminar nuclei seems to have an important effect on the speaking and the motivation. The anterior group of this intralaminar nuclei has several subdivisions like central, medial, paracentral, and the central lateral nuclei. The central lateral nucleus connects mainly with the parietal and the temporal association areas, and the paracentral has connections with the occipitotemporal and the prefrontal cortex. And the central medial nucleus connects to the orbitofrontal and the prefrontal cortex, and the cortex on the medial surface of the hemisphere. And afferents from this anterior group will be going on to the brainstem reticular formation and superior colliculus and the pretectal nuclei. The central lateral nucleus receives afferent fibers from the spinothalamic tract also. And efferents from this group of nuclei, they travel to the central, to the orbitofrontal and the prefrontal cortex, mainly from the central medial nucleus, and to the cortex on the medial surface of the hemisphere also. And the caudal group, it has two divisions like centromedian and the parafascicular nuclei. The afferents to this posterior group will be from the internal segment of the globus pallidus, pars reticulata of substantia nigra, deep cerebellar nuclei, and the pedunculopontine nucleus of the midbrain and the spinothalamic tract. And efferents will be to the striatum. The reciprocal connections will be there with the motor, premotor, and the supplementary motor areas of the brain. And the periventricular midline nuclei, as I told you, there will be some clusters of neuronal cell bodies in the subependymal gray matter of the adjacent to the thalamus. And this has rhomboid nucleus, reunions, and the peritoneal nuclei. And this nuclei has afferents from hypothalamus, periaqueductal gray matter, and spinothalamic tract, and the medullary reticular formation, and the pontine reticular formation. And efferents from this paraventricular nuclei will be going to the hippocampal formation, amygdala, and the nucleus accumbens. And there are reciprocal connections with the orbitofrontal cortex to the periventricular, the midline nuclei of the thalamus. And this periventricular nuclei are lined with ependymoma towards the third ventricular surface. And the reticular nucleus, as I told you in my previous slides, this is like a shell-shaped nucleus, which is overlying the external medullary lamina on the lateral surface of the thalamus, which will be extending from the anterior pole of the thalamus to almost to the pulvinar area, and even the geniculate nuclei here. And it is the only nucleus that does not project onto the cortex. This nucleus receives inputs from the thalamic nuclei and the cerebral cortex and sends out projections that circle back to the cerebral cortex. It is involved in gating and modulating information as a relay information of the thalamus. And it receives input from the reticular formation that projects onto the thalamic nuclei, regulating the flow of information through these areas to the cortex. It mainly regulates the alertness and the attention, and it receives afferents from the nucleus cuneiformis of the midbrain, frontal cortex, and the temporal cortex and the occipital cortex. Efferents from the reticular nuclei will be mainly to the body of the thalamus and then the contralateral dorsal thalamus. We have gone through a lot of connections. As I told you, thalamus has thousands and thousands of connections with various parts of the brain. But just summarizing, like what is most important from the neurosurgeon's point of view, particularly neurosurgeons who are working in the field of functional neurosurgery. The anterior nucleus has afferents from mammillary bodies and efferents to cingulate gyrus. And ventral anterior is connected with basal ganglia. And ventrolateral nucleus is connected with cerebellum, basal ganglia, and substantia nigra. And ventrolateral posterior nucleus is mainly somatosensory connections from the trunk. And the medial nucleus is from the head and neck. And medial geniculate body from the auditory connections, and lateral geniculate body from the visual connections. And pulvinar will be receiving information mainly from the superior colliculus and area 17 and 18. So this is like the important information which needs to be remembered. And main projections which are very like essential to remember are the anterior group will be projecting onto the cingulate gyrus, and ventral anterior group to the Brodmann 8 area, and the ventrolateral to the Brodmann area 4, and ventroposterolateral to the Brodmann area 3, 1, 2, and ventroposteromedial will be to the Brodmann area 43, and medial geniculate body to 41 and 42, and lateral geniculate body to the area 17. And this nuclei has some relevance in the functional neurosurgery, as I told you. Particularly, ventrolateral nucleus is important when we are thinking about deep brain stimulation in cases of tremors and dystonia. And for pain modulation and management, VPL and VPM are very important. And in Parkinson's disease, GPI is important, and STN is also important. And in epilepsy patients, anterior nuclear group is important. And in OCD and resistant depression, the medial dorsal nucleus is important. And Tourette's, centromedian nucleus is important. So as I was telling you, this is the thalamic fasciculus here. The dentatorubro-thalamic fibers, they cross over, and then the lenticular fasciculus from GPI will be connecting here between the zona incerta and the subthalamic nucleus, and ansa lenticularis will be connecting below the subthalamic nucleus. And this is the orientation here. The ansa lenticularis will be passing over the posterior limb of the internal capsule, whereas the lenticular fasciculus will be crossing under the posterior limb of the internal capsule here before they join the thalamic fasciculus. And this is again a summation of what I told you, the main important connections with the thalamus. And if we remember this color coding of this nuclei, and there is corresponding color coding on the cerebral cortex, which will be showing that the yellow nuclei will be projecting these yellow areas. And this color-coded projection, it helps in understanding the orientation of the projection of the thalamic nuclei. And homunculus in the thalamus is very complex. One thing to just make it simple and understand is the head part will be oriented medially, and the limb part will be oriented laterally here. And it is complex and difficult to understand also. And if you come to the blood supply of the thalamus, mainly thalamus receives supply from the PCA, the perforators, and the thalamogeniculate branch, and the posterior choroidal arteries. And PCOM also gives rise to thalamoperforators to supply the thalamus. And the anterior choroidal, which usually supplies the internal capsule, gives off some branches to the adjacent part of the thalamus, which is lying just as a neighboring structure to the internal capsule. And this supply is very important in understanding the thalamic syndromes. When the posterolateral part of the thalamus is affected, it ends up with sensory and the speech abnormalities, Jering-Rosas syndrome, and pain perception dysfunction, particularly when the ventro-posterior nucleus is affected. And the medial thalamic syndromes are associated with disorders of consciousness, and thalamic neglect, and thalamic amnesia, and akinetic mutism. The anterolateral thalamic syndromes is associated with paresis, ataxia, and motor incoordination. And these are the various kinds of tumors we come across in the thalamus. This is a glioma in the posterior part of the thalamus here. And this is again a glioma here on the superior part of the thalamus. And this is an abscess which is there in the posterior part of the thalamus here. And this is again a glioma which is extending from the thalamus into the adjacent lobar structures also. So this is again a glioma here. And again a glioma which is spreading across also. So when we talk about the management of tumors in the thalamus, there are different protocols like simple observation when the patient is not doing very well and very moribund and not fit for surgical interventions, or is a very small lesion which is not growing over time. Simple observation will be enough there. And when we think about surgery, a simple stereotactic biopsy or endoscopic biopsy followed by radiotherapy and chemotherapy, with or without a shunt placement. And when the lesion is very big and causing hydrocephalus and other neurological deficits, one will be thinking about excision of these lesions. And when we think about excisions, as I was telling you the details of the macroscopic anatomy of the thalamus, there are 4 described surgically accessible surfaces of the thalamus by Assergate. And the purple one is the third ventricular surface, and the red colored one is the velar surface, and the yellow color one is the lateral ventricular surface, and the green colored area is the cisternal surface. If you remember when I showed you the cisterna magna, this part of the thalamus will be projecting into the cisterna ambiens, and this is the cisternal surface here. And the velar surface is covered with the choroid plexus and the thalamostriate vein, all those structures here. And this is the walls of the third ventricle, and this one will be exposed part of the thalamus in the lateral ventricle here. So these surfaces are important when we are trying to approach tumors in the thalamus. And Splezer has proposed a way to deal with lesions in the thalamus. When the lesion is anteroinferior orbidozygomatic approach and then going through the Sylvian fissure, the supracarotid approach is the important thing. And when the lesion is located medially in the thalamus, it is the anterior interhemispheric approach with ipsilateral transcallosal axis. And when the lesion is located little laterally, again the anterior interhemispheric approach, but with a contralateral transcallosal approach will be ideal. And when the lesion is located posterior-superiorly in the thalamus, the easy access will be taken through the posterior interhemispheric transcallosal approach. And when the lesion is posterior-inferior, if it is very lateral, then access can be taken through the parieto-occipital transventricular route. And when it is located medially, the posterior-inferior part, the suboccipital supracerebellar infratentorial approach will be ideal. So when the epicenter of the lesion is in the anterior part of the thalamus, which is extending little over 2 centimeters from the lateral border, a transfrontal approach will be useful. And a transtemporal approach will be useful when the lesion is located in the lateral part of the thalamus and it is extending into the basal ganglia and adjacent lobes and extending beneath the temporal cortex also. The transtemporal approach will be easier. And it is also useful, the transtemporal approach is also useful in the lesions when at the junction of the thalamus and the cerebral peduncle. And transinsular approach for the lesions which are located in the lateral part of the thalamus with extension into the basal ganglia. And subtemporal approach will be better in lesions involving the pulvinar with posterior extension over to the adjacent structures. And in lesions which are arising located in the junctional area of the thalamus and the cerebral peduncles. So depending upon the location of the lesion, all these approaches have to be thought about and then designed and to gain better access and remove the lesions as much as possible without causing much morbidity and mortality. As I told you, this is one lesion in the anterior inferior part of the thalamus. And this can be approached through orbitozygomatic transfillion and the supracarotid approach. And this is a lesion in the medial part of the thalamus. This is approached through the anterior interhemispheric approach with ipsilateral transcallosal splitting. And if the lesion is located little lateral in the anterior part of the thalamus, this can be approached through the anterior interhemispheric approach, but with a contralateral transcallosal approach. And if the lesion is in the superior part of the thalamus here, the access will be through the posterior interhemispheric transcallosal approach to reach out that region. And if the lesion is posterior inferior and little laterally located lesion, we have to gain access to the parieto-occipital transventricular route to reach the lesion to get a better access. And if the lesion is located posterior inferior but medially, easy access will be through the suboccipital, infratentorial, and the supracerebellar axis. And with this statement on the outcome, I would like to conclude my talk. These lesions are located deep, and there is a complexity in approaching these lesions and even limitation in like how much lesion we are able to remove and all. And most of these pathologies will be high-grade pathologies. They are associated with high morbidity and poor outcome. I think I have covered comprehensively about the anatomy and the applied anatomy aspects from a neurosurgeon's point of view. Thank you.
Thank you very much, Professor. Very nice presentation and very nice details about the thalamus and its nuclei and also about these connections. If anyone have any questions for Professor Sayed Amir Basha, please go ahead, ask in the chat or ask directly. Okay.
Yeah.
I see very no questions. So thank you very much, Professor Sayed, for this amazing presentation.
Thank you. Thank you. Thank you for the opportunity. I'll be
We are
looking
honored.
forward, for more interactions like this.
Thank you, and we are honored by your participation with us.
Thank you. Thank you so much. Thank you so much. Allah.
So, if there is no any questions, we can conclude our sixth session of the comprehensive neuroeducational course. and see you all in next Friday, inshallah, with more sessions and more speakers. So thank you, everyone, and see you next week,
Thank you.
inshallah. Thank you, Professor.